Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Measurement of Cardiac Function Using Pressure Volume Loops in Swine, featuring Dr. Pedro Ferreira, postdoctoral researcher within physiology and cardiothoracic surgery at the University of Porto. Today, he will present a deep dive into his work using pressure volume loops in large animal models of heart failure. I wanted to take this moment to thank our partners at the American Physiological Society and the sponsor for this event, 80 Instruments, for making it all possible. 80 Instruments creates industry-leading software and hardware tools for life science researchers and educators. For over 30 years, 80 Instruments' mission has been to support scientific discovery, and they are proud to be in strategic partnership with the American Physiological Society to support innovation in the life sciences. 80 Instruments offers a range of solutions for accurate physiological measurements, and with the ability to integrate multiple data sources, systems can evolve as your experiments do, ensuring quality results wherever your research takes you. And now with that, I'm going to welcome our speaker, Pedro, to join me. Hi.
Hi.
Thanks for being here. Please take it away whenever you're ready.
Thank you. Good afternoon, everyone. My name is Pedro Ferreira, and today I will be talking to you about pressure volume loop analysis in peaks. So first of all, I would like to thank Sydney and Insight Scientific and Jake and APS for having me and helping me in the preparation of this webinar, and also the people at 80 Instruments for inviting me to share our experience. I am a biologist working in the cardiovascular field and mainly focus on looking into cardiac function in different animal models. So I work at the Cardiovascular R&D Center, which is located at the Department of Surgery and Physiology at the Faculty of Medicine of the University of Porto. So during this webinar, I will be talking a little bit about how we perform PV recordings and hopefully clarify any doubts you might have regarding the technique or convince you of the utility of recording such measurements in heart failure research. If you're thinking about performing pressure volume experiments for the first time, or if you have any difficulties or questions, I hope this presentation is helpful, and I'll be more than happy to answer any questions you might have. So as I mentioned, we're based at the Cardiovascular R&D Center at the Faculty of Medicine of the University of Porto, where I've been working for the last 15 years. So this research unit, UNIQUE, was created in the 90s with the goal of closing the gap between basic science and clinical research in cardiovascular diseases. Since its beginning, UNIQUE has significantly grown, and we now have more than 60 PhD researchers and 80 non-PhD researchers, including medical doctors and PhD students, with representatives from most STEM fields. UNIQUE is located in Porto, in the north of Portugal, and we benefit from a close proximity to the main hospital in the north of Portugal, Hospital São João. The sharing of a building facilitates not only networking between physicians and researchers, but also allows a significant number of research projects to include clinical data or samples. Our scientific network expands throughout Europe and North America and is composed of similar research labs focusing on heart failure research, as well as pharmaceutical companies developing new therapeutic approaches. On top of the diagram, you can see the Instruments and Millar, with whom we also share a long history, not only as clients of most of their products, but also as partners in workshops and prototype testing. In our experimental surgery lab, we focus on national and internationally funded research projects, and we also provide research services to the pharmaceutical and medical device industry. So far, all research performed at our large animal lab is related to cardiovascular diseases, and most of it ends up with the measurement of pressure volume loops. In terms of animal models, we focus on both left heart disease, including ischemia, reperfusion injury, and aortic stenosis, and right heart disease, using a model of chronic thromboembolic pulmonary hypertension and a model of pulmonary artery bending. So in parallel to our research projects, we also provide postgraduate training due to our integration in the Faculty of Medicine, where pre-graduate and postgraduate courses are taught, but also due to our close proximity with the Hospital São João, where a lot of interest and necessity exists to provide training to young physicians or demonstrate new technologies. And while these workshops are targeted to a very specific audience and do not lead to any scientific advances per se, being exposed to a lot of different medical techniques and industry partners is a huge benefit when running a large animal lab, as it opens up a lot of new possibilities for industry collaborations and potential off-label applications of medical devices specifically applied to our research projects. To run a large animal lab, we need a large team, and this is made up of researchers from different backgrounds. So starting from the top right, we have our anesthesiologists, including Professor André Lourenço, which was my PV loop mentor, who taught me both the theory behind PV analysis, the skills required for rodent PV acquisition, and more recently, the medical techniques needed to perform percutaneous PV measurements in large animals. We then have our team of cardiothoracic surgeons who perform most of our recovery thoracic surgeries, including Professor Adelino Leite Moreira. He is the head of the Cardiovascular R&D Center and the renowned cardiac surgeon who was the main driving force for UNIC to become a reference in cardiovascular physiology. We also count with the help of interventional cardiologists, which not only bring important insight into the different techniques that we need to perform, but also serve as a great link to the medical industry, facilitating access to different catheters that we can apply to our daily experimental protocols. On the left, we have our team of veterinarians and animal caretakers, which make sure that our animals are well taken care of and that everything complies with ethical standards. And last but not least, we have our team of biologists, which includes myself and a very hardworking PhD student, Liliana, without whom running the large animal lab would not be possible, including the recordings you will see here. She will be the extra pair of hands you will see on some of the videos. So starting to talk about the subject that brought us here, I always like to start talking about PV loops by showing this slide. On the left, you can see a set of several PV loops, and if you pay attention to the green, the yellow, and the red one, they all share a similar end systolic pressure value. If one would only analyze LV systolic pressures, when we looked at these three patients, we would say that they were similar, while in fact they show very different cardiac function. More importantly, and now looking at the right panel, and keep in mind that this is real data from a protocol that we ran last year, if we looked at only pressures, we would say that these two rats submitted to pulmonary artery banding were exactly the same. Indeed, the rat with a red PV loop was treated with a new therapeutic compound, and by looking at volumes, we could clearly see a huge effect in terms of ejection fraction in these animals, something we would have missed if we only looked at pressures. Furthermore, another interesting aspect about PV loops is that they are translational and can be applied from mice to men. In our lab, we apply it from small animal models of several different cardiac pathologies, including genetically modified animals, to large animal models of cardiac disease. While not currently performed in our hospital, PV loops can also be done in patients, being of great aid in guiding certain interventions such as pacemaker optimization. So in large animals, and the same in small, there are two approaches to acquiring PV loops, both with its advantages and disadvantages. So the closed chest or percutaneous model is a less invasive and more physiological approach, which in theory allows for longitudinal studies to be performed. However, it does require fluoroscopy or X-ray imaging and makes it difficult to manipulate afterload. On the other hand, the open chest approach does not require imaging and therefore no X-rays are needed and allows easy access to all cardiac structures, making it easy to manipulate the load in any way. Despite that, it is a terminal procedure, which is extremely invasive, much less physiological, and can lead to significant myocardial damage. In our lab, we always perform the closed chest approach, except when the protocol includes a terminal open chest surgery where access to the aorta is restricted, as it is the case for extracorporeal circulation protocols. Just for reference, here is an example of an experiment where we perform bi-ventricular PV loop analysis using two PV catheters simultaneously, all of which introduced using the closed chest approach. One can see a ventricath in the left ventricle, another in the right ventricle, a Swan-Ganz in the pulmonary artery for cardiac output measurement, an inferior vena cava balloon for preload reduction, and a microcath in the aorta for pressure gradient determination, as this animal was submitted to aortic bending. With the correct setup, you can easily collect all of these data simultaneously and significantly shorten your recording time if biventricular function is of interest to you. So in this photo, you can see our large animal lab where we perform all of our procedures. So it is a hybrid operating room, as it allows for both cardiac surgery and fluoroscopy-guided procedures to be performed. So we have our radio-transparent surgical table with a warming pad on top of it, our ventilator and patient monitor, our syringe pumps for anesthetic delivery, the fluoroscopy system to guide the procedures, and then an ultrasound system for transthoracic echocardiography and to perform ultrasound-guided vascular accesses, and finally, our PV loop station. So with regards to our PV loop station, this is a simplified scheme of the setup that we currently have. So first, we run our fluid field signals through a pressure signal conditioner, represented by the red dot, and which feeds the pressure signals into the power lab. While one could simply connect the sensors to a bridge amp, the pressure conditioner allows us to perform a digital calibration, which is much easier and faster to do. And furthermore, this pressure conditioner allows us to connect up to 2 microcats if we need to. Second, we have our cardiac output monitor, the blue dot, which luckily has an analog output that can be extracted with a BNC cable and fed into Power Lab. As you will see later, different options exist when recording your cardiac output, but this is our preferred approach when doing percutaneous PV loop analysis. Third, we have our MPVS Ultras, the green dots, which allow the connection of the ventricats or microcats and feed the signals into the Power Lab. In our case, we run 2 Power Labs in the same computer, receiving all volume segment signals from both MPVS Ultras. However, in order to run a biventricular loop experiment, you will need a second computer just to connect the second MPVS Ultra, as it requires the MPVS Ultra control software to be open on a separate computer. And lastly, we have our BioAmp, which records surface ECG. So for both the fluid field and ECG signals, we usually bypass these signals in order to have them on both the patient monitor and lab chart simultaneously, without having to duplicate all of the cables and sensors. And we do this simply because physicians are used to working with patient monitors, and it's much easier to detect changes in hemodynamics or any emergent situation that occurs. So in terms of the consumables we need to perform PV loop analysis, this is an overview of what you usually use. And during the next slides and videos, you will see a demonstration of their use. So first, we have our introducer sheaths on the top left, which are entry point into the vascular system of the animal. Then on the top, we have our angiographic catheter, which although it is usually used for coronary imaging, we use it to help guide our J-tip guide wire into the left ventricle when we need to. Third, we have our guiding sheaths, and these can be a long sheath to reach the LV through the femoral artery, or a shorter sheath to reach the LV through the carotid artery. Through these sheaths, we introduce our ventricath, which in our case is the 507, and that has a pigtail tip, which makes it atraumatic and avoids damage to the left ventricular apex. Then we have our Swan-Ganz catheter, which is introduced through the jugular vein and allows for measurement of pulmonary artery pressures and cardiac output. And we have our inferior vena cava balloon, which is introduced through a femoral vein and is placed below the right atria to occlude blood return when we need to. Lastly, you have other accessories and drugs, such as heparin, which is required when performing catheterization, contrast that can be used to identify the cardiac anatomy, and hemostasis valves, which are very helpful when using catheters and sheaths in off-label applications. So I will now take you through our protocol in a step-by-step manner and describe the main steps of performing PV loops in pigs. So before we get into the actual PV loop experiment, the animal needs to be prepared. So the day before the experiment, the animal should be fasted, and we usually do this by leaving a little bit of food the day before the procedure, since the maintenance of the animal housing is usually done in the morning, meaning that during the day the animal will eat the rest of the food and then fast during the night. Then on the day of the procedure, we need to anesthetize the animal through an intramuscular injection of an anesthetic cocktail. And this includes ketamine, midazolam, and dazuepiron. And we usually do this by connecting a 20 cc syringe to a 1 meter line extension, followed by a butterfly needle. And with this setup, we can calmly approach the animal, stick the needle in either the neck or the leg muscle, and safely inject. Even if the animal moves, the 1 meter line extension gives us a lot of margin to move around with the animal, avoiding removal of the needle and anesthesia waste. So once the animal is down, we get its body weight and we transport it to the operating room. There, we place an intravenous catheter in an ear vein, which usually is the right one, which is closer to the syringe pumps, and we connect the 3-way ramp, which allows us to infuse up to 3 drugs plus a saline drip. For anesthesia maintenance, we usually do propofol and fentanyl, and furthermore, we run our saline drip through an infusion pump, which allows us to control the volume the animal is taking throughout the procedure. Once the animal is secure, we move on to intubation. And after ensuring that the animal has no reflexes, usually after a fentanyl or propofol bolus, we use a laryngoscope to visualize the vocal cords, and we introduce a bougie, which will serve as a guide for the endotracheal tube placement. We then connect a tube to our ventilator and mechanically ventilate the animal, ensuring adequate and expired carbon dioxide levels. Lastly, we attach electrodes to the animal to record ECG, place an oxygen saturation sensor in the ear or tongue, wherever the best signal is obtained, and we introduce an esophageal temperature probe. After this, we're ready to proceed to obtain our vascular accesses and catheterize the LV. So this is just an example of how the animal looks once fully catheterized for LV pressure volume recordings, with a PV catheter and IVC balloon through the femoral vessels and the Swan-Ganz through the jugular vein. So coming into our demonstration per se, we've prepared a set of videos that attempt to demonstrate different procedures. So on the left, you have a scheme of our preparation and of the images you will see. So all the procedures will have an overview image of the catheter manipulation, and then in parallel, you'll have either the X-ray, ultrasound, or a recording of lab chart. So first, we'll take a look at obtaining the vascular accesses. And I'll just pop up. So here we first identify the femoral artery and femoral vein using ultrasound, and you can do this by looking at the artery and seeing that it does not, first it's pulsatile and it does not compress under pressure, while the vein, when you apply pressure to the skin, it decreases its size. Then under ultrasound guidance, we advance the needle with a syringe on its hub until we are at the vein wall. And once we puncture the vein, we make sure that we are able to aspirate blood easily. If blood is not easily aspirated into the syringe, then you need to reposition the needle. And once you are sure that you can easily aspirate blood, then you can remove the syringe and advance your guide wire into the vein. Make sure that you advance a sufficient length of the guide wire to safely remove the needle, and you can advance for your artery cannulation. So before placing the venous introducer sheath, we get the second guide wire in the artery first. So to do that, we use a needle without the syringe so that we can see blood flow coming out of the needle when we are inside the artery. So we first puncture the thick skin that the pig has, and then we try to perforate the artery in its anterior wall, which we've just done. And as you see, there is a lot of pulsatile flow, which is a good sign that we are in the correct position in the arterial lumen. And then similarly, we advance the guide wire into the artery a sufficient amount to safely remove the needle. Once both guide wires are in, we can then advance our introducer sheaths. For smaller introducer sheaths, which is this case, a 7 French introducer sheath, we don't need to pre-dilate our path, so we can just directly introduce the sheath. But for larger introducer sheaths, which will be the case of the femoral vein introducer, we should dilate before. Here we're just checking that there is good flow and then flushing the sheath with heparinized saline so we don't get any blood clots when we introduce our catheters. And then we first make a nick in the skin on the femoral puncture place. We dilate with an 8 French introducer first. So we go step by step, going up to the 10 French size, which will be the size of the sheath. Once we have pre-dilated with the 8 French, we dilate with a 10 French, which is the dilator for the specific introducer sheath that we're going to place. And once we're done with that, then we advance our introducer sheath. Make sure to always apply pressure with your left hand to avoid excessive bleeding. And then once you're done all your pre-dilation, you can introduce your introducer sheath. Make sure that the 3-way stopcock at the end of the side port is always off to the patient. Otherwise, when you introduce the sheath and remove the dilator and the guide wire, there will be a lot of bleeding, especially if it's an artery. And then as for the artery, we confirm that we have good flow back of blood, and then we just flush the system with heparinized saline. So once we have our femoral excesses, then we move on to the neck, and we end up with something like this. So the introducer, just give me a second. On the left side, you can see the different access points that we usually have, and that are represented in all the videos that you will see. So the ventricath will go through an 8 French introducer on the right femoral artery. The IVC balloon will go through a 10 French introducer on the left femoral vein, and the second femoral artery introducer, which was the one you saw us performing a few moments ago, is placed for blood pressure monitoring. So for the neck, we place the 9 French introducer on the right jugular vein for placement of the Swan-Ganz catheter, and the 9 French introducer on the left carotid artery for introduction of the PV catheter through the carotid approach. All of these vascular accesses were obtained using the Seldinger technique, which, as you can see on the right side of the slide, it's a technique that involves the introduction of the thin wall needle into the target vessel, and then through this needle we advance a guide wire, which, as the name suggests, will serve as a guide for the advancement of the introducer sheath of the wire, and then you'll get your vascular access. So the introducer sheath is a plastic tube which has an hemostasis valve at its end on the side that stays outside of the animal, and this prevents blood from coming out while allowing the introduction of catheters through it. So it also has a side port with a 3-way stopcock that can be used for monitoring pressures or administering fluids or drugs. So this introducer sheath comes with a dilator, as you previously saw, and which fits perfectly inside the introducer sheath and allows for it to be safely introduced into the artery or vein without damaging any surrounding tissues, as it creates the perfect transition between the guide wire, which is already inside the vessel, and the introducer sheath itself. So there are several techniques for gaining vascular access, all of which have their plus and minuses. Mostly used by physicians, the palpation technique entails the identification of the femoral artery by feeling its pulse. It does not require any specialized equipment and is the fastest to be performed. Despite that, it does require a lot more experience and can be associated with a higher failure rate. The cut-down technique involves the dissection of the surrounding tissues until the vessels are directly seen, and while it does offer a direct visualization of the vessel, it is more time-consuming, requires surgical skill, and compromises animal recovery. Lastly, the ultrasound-guided technique, which you just saw, is relatively fast, allows direct visualization of the vessel, and has a low failure rate. It does, however, require an ultrasound system, but this is usually available in most experimental labs. So after all your vascular accesses are performed, we can move on with the protocol, and we usually introduce our Swan-Ganz catheter first, as it allows us to monitor pulmonary artery pressures and cardiac output throughout the rest of the procedure. So I'll just pop up the video. So the Swan-Ganz catheter is a plastic catheter with a balloon at its tip. So we first check that the balloon is okay, and then we flush the lumens of the Swan-Ganz to make sure that there are no air bubbles. This is a flexible catheter that, once inflated inside the heart, will follow the blood flow. So first we introduce it 15 to 20 centimeters until we are free of the sheath, or until we see it at the tip of the right atrium. Then we inflate the balloon, in this case with 1.5 cc's of air, and you will be able to see the balloon being inflated there. And then we just push the catheter forward, and it will follow the blood flow into the RV, into the pulmonary artery, and then it will get stuck in a wedge position. Once there, you can remove or deflate the balloon, and then pull the Swan-Ganz catheter a little bit back, and you will be in your pulmonary artery or in the main trunk, where you can measure pulmonary artery pressure or record your cardiac output. So to record cardiac output, you just simply use the proximal line, which is this blue line connecting to a proximal port in the Swan-Ganz, and you inject 5 milliliters of room temperature saline. So when you inject this this cold, or at least colder than the body temperature solution, at the tip of the Swan-Ganz catheter, there's a temperature probe that will detect this shift in temperature. So you'll get a steep decrease in temperature when you quickly inject your cold saline, and then temperature will slowly recover to normal values. And using this temperature change, then you can analyze your cardiac output either using your clinical monitor or the left chart module to analyze cardiac output. So going back to our slides. So in terms of Swan-Ganz catheters, there are two options that you can choose from. So the thermodilution and the continuous cardiac output. So while the thermodilution, which is the one that you just saw, is cheaper and requires a smaller size introducer, it does require fluid administration and only gives you a single time point measurement. On the other hand, the continuous cardiac output gives you an ongoing cardiac output value and also allows for mixed venous saturation monitoring. Importantly, since this works by hitting a resistance placed near the catheter tip, it does affect the conductance signal, so it has to be off when performing your recordings. Both options allow for the signal to be uploaded into LabChart, either in the form of temperature reading, which you can use to analyze cardiac output with LabChart using its module, or a direct cardiac output value. Of note, always be careful when advancing a Swan-Ganz catheter, especially if you are doing it blindly, as accidents can happen, as you can see here on the right side. This is an example of a loop that was formed in the Swan-Ganz after we tried to advance it without imaging. After a few back and forth movements, we were unable to pull it out through the sheath, and this was the reason why. So next, after we have placed our Swan-Ganz catheter in the pulmonary artery, we move on to left ventricular catheterization for the placement of the PV catheter. So catheterization of the LV requires the introduction of a catheter or a sheath inside the left ventricle through which the ventricath can then be advanced. So advancing the ventricath alone might be possible, but it could lead to damage to the catheter itself or the aortic valve. To reach the LV, we first introduce a long wire, usually 200 centimeters in length, and with a J-tip so that it is atraumatic. To help steer this guide wire, we sometimes use an angiographic catheter with a shallow curve, usually a multipurpose curve, that allows us to direct the J-tip of the guide wire into the aortic arch, aortic valve, and ultimately the left ventricle. So once the guide wire is in the LV, the angiographic catheter is removed, leaving the guide wire in place, and the length of this guide wire needs to be sufficient so that the catheter can be pulled out while still being able to control the guide wire and leaving it inside the LV. So next, you need to advance your sheath or guide catheter over the wire, and we prefer to use a sheath as it comes with a dilator and makes advancing over the guide wire much safer. Using a guide catheter is also an option, but because guide catheters do not have a dilator, the space between the guide catheter tip and the guide wire can cause damage to the aortic valve. Once your sheath or catheter is inside the LV, you can confirm the anatomy by injecting contrast, but this is not always required. And following confirmation of its positioning, you can advance your pre-calibrated PV catheter and you should be able to start seeing some loops. Lastly, always make sure that your sheath or catheter lengths are appropriate, that they are long enough to reach the LV, but not too long that they do not allow all the volume segments to be out of the sheath. And I'm going to pull another video in. So here will be catheterizing the LV. So this is the angiographic catheter with a shallow curve, the multipurpose curve. And this catheter already has the guide wire pushed through inside it. I'm just advancing the catheter a little bit until it's out of the sheath, and then we'll start advancing the guide wire into the heart. And you see the guide wire coming up the descending aorta. Then we fix the guide wire in place, and we advance the angiographic catheter all the way up to the heart, which you will see in a second. And you see that the Swan-Ganz is already in place there. Then the angiographic catheter should show up in a second. There it is. And as you see, it has a very shallow curve that we can use to rotate the catheter and force the guide wire to be pointed toward the specific place in order to make it go around the aortic arch and into the left ventricle. So here we're trying to do it a couple of times. And because we did not succeed, we decided to advance the angiographic catheter a little bit more, all the way up to the aortic valve, so that we would have a closer proximity to it and more easily advancing the guide wire through the valve. Again, we secure the guide wire in place and we advance the angiographic catheter over it. If you let the guide wire just go forward, it might damage the aortic valve. And then here we just rotate the angiographic catheter to different positions while going back and forth with the guide wire until we're able to cross the aortic valve and into the LV, which we just did there. Once the guide wire is inside the LV, we can then remove the angiographic catheter while leaving the guide wire in place. And here again, it's important to note that you have to take into account the length of the guide wire, because you have to pull out the whole angiographic catheter out of the sheath while still leaving the guide wire inside the LV. So once your angiographic catheter is out, you can have your assistant hold it in place, which will happen in a second. There, and then you can take out your angiographic catheter and substitute it by the sheath. So you see the sheath there with the dilator, which was the gray tip after the blue tip of the sheath. And then we fix the guide wire in place and we advance the sheath over it. It is important not to allow the guide wire to move too much inside the LV, as it will induce a lot of arrhythmias and maybe cause some hemodynamic instability. And then we just advance the sheath over the guide wire. And I'm just going to pause the video here for a few seconds, because as you see here, the length of this sheath is just enough to reach the LV in this animal. So this is another important thing that I need to press, which is always make sure that you have long enough sheaths that reach the left ventricle of the animal you're using, but not too long that they don't allow all the volume segments to come out. So as you see, the sheath is pushed all the way in, and when we inject contrast, we're right at the limit of the left ventricular outflow tract. Then we calibrate our surface pressure of our PV catheter, and we can introduce it through the sheath. As you see here also, we changed the Dewey-Borst Y adapter that came with the sheath to this hemostatic valve, which is much easier to use and shorter. So it does not occupy as much space as the Y connector, and it's much easier to advance equipment through it. And you see here the volume segments of the ventricath coming up the sheath, and then you see the pigtail of the ventricath inside the LV, pointing towards its apex and nicely aligned with the long axis. Then we pull the sheath out. You see its tip coming out and releasing, in quotes, all of the segments of the ventricath, and then you have your loops. Then you check your different segments and you make sure that you are in the correct position. And if you need to adjust anything, you can do it now. So this was the femoral approach. But another alternative that you can use is the carotid approach. We do not use it as frequently, as it is more complicated to catheterize the carotid artery than the femoral artery. And also for recovery purposes, it's much easier to do it with the femoral than with the carotid. So for the carotid, because there is a much straighter path between the introducer sheath and the ventricle, we don't need to use an angiographic catheter to help us guide the guide wire into the LV. So we just push the guide wire directly through the sheath. As you can see here, it's a shorter sheath than the one we just used. And after a few tries, the guide wire goes inside the left ventricle. And once it's there, you can advance the sheath over it. Similarly to what we did before, you can see the radiopaque marker of the sheath. Always pay attention that the dilator is coming out another 2 or 3 centimeters after this radiopaque marker. So don't push this too much into the apex of the LV, or you can perforate it. And then you can confirm the position of your catheter by performing contrast injection. You get a nice view of your anatomy. And then you also can mark where the left outflow tract ends and where the aortic valve begins. And once you're happy with the position, you can advance your ventricath, similarly to what we did for the femoral approach. In this case, this sheath does not come with a 2V Borst Y connector. It comes with a crosscut hemostasis valve, which is similar to the orange one that we substitute the Y connector for. So you just slowly and carefully introduce the ventricath to avoid any kinks. Otherwise, the catheter won't last too long. And then similarly as before, you will see the volume segments coming down the catheter and then the pigtail forming after the radiopaque tip of the sheath. And you'll see that in a second. Here it is coming, and then you see the pigtail coming out of the sheath, and then you advance the ventricath, you pull the sheath out until you release all of the volume segments, and you pull the sheath all the way up to the ascending aorta, and then you adjust your ventricath position by pushing it further a little bit more to make sure all segments are in and you're perfectly aligned with the major axis. And then you check your loops and you should see a very nice looking piece of toast. And there you have it. So you can also, at this step, inject contrast in the aorta, and this will tell you exactly where the aortic valve begins and tell you if you need to exclude any of the segments or if you need to adjust your catheter position, etc. So moving on, once your ventricath is inside the LV and you're happy with your loop, we move on to the inferior vena cava balloon. So I'll just pop up the video for that. So for the IVC balloon, and as I will describe in a little bit, we use a sizing balloon that can be pushed through an 8 French introducer. This is a 30 millimeter balloon, which can occlude easily the inferior vena cava of a pig this size, which was around 60 kilos. We always use a guide wire through the distal lumen of the balloon to make sure that we're not damaging anything and that we can easily control where the balloon is going to be located. And then we advance the balloon just until the cardiac silhouette begins at the level of the diaphragm. And you can see that by the radiopaque markers that the balloon has. And once you're happy with the position, you can do your IVC occlusion. You stop the ventilation. As you saw, the loops became very stable. Then you inflate the balloon with air. You see that the balloon is wide on the inside. And then you have your end-systolic and then diastolic pressure volume relationships. There was a little arrhythmia there in the middle, and that's it for the IVC balloon. So going back to the slides, so we have several choices when it comes to balloons. So there are a few balloons that are specifically designed for vena cava occlusion in the case of severe hemorrhage during certain procedures, for example, but these are less frequently used, and therefore getting access to them is much harder. So the options we have are based on routinely used balloons in the invasive cardiology laboratory, and namely the valvuloplasty balloons, option 1, and sizing balloons, option 2. So the Fogarty catheter is less frequently used in the cardiology service, so we rarely consider its use. So the valvuloplasty balloon is a very resistant balloon that will not easily burst, but it has a very large crossing profile, meaning that it needs a very large introducer sheath in order to be deployed. This is especially important when recovering the animal is required, as creating a 4 millimeter hole, which is a 12 French introducer, is very different than creating a 2.6 millimeter hole, which corresponds to an 8 French introducer. So the sizing balloon is a less resistant balloon, but that can be damaged more easily, but it only requires an 8 French introducer to be inserted into the body. And since occluding the inferior vena cava does not require a lot of pressure, this is our preferred option for most of our procedures. So when determining the size of the balloon to choose, you can always perform a venogram beforehand and estimate the size of the EVC to ensure that the balloon that you choose is sufficient to completely occlude it. Having a larger balloon than needed should not be a problem, as one can monitor ventricular pressures while occluding the balloon to make sure that enough inflation has been applied. While according to the manufacturer's manual, the balloon should be inflated with saline or a mixture of saline and contrast, we always inflate our balloons with air. Air can still be visible under X-ray, and it allows us to reuse the balloon as many times as needed. When occluding the IVC, some arrhythmias can occur, and in this case, catheter positioning might be the issue, as decreasing the size of the cavity might lead to the catheter being pushed too far into the wall. Other times, when performing an occlusion, the pressure sensor touches the LV wall, which can lead to overestimation of end-systolic pressures. Ideally, always perform the occlusion with ventilation stopped, as you saw in the video, to avoid any breathing artifacts. If the animal is attempting to breathe spontaneously and you are sure that all the ventilatory parameters are optimal, one can consider a muscle relaxant such as rocuronium. So once your IVC is occlusions are done, then you can move forward to your hypertonic saline, or you can do it before IVC occlusion. It depends on your own protocol. And for that, I'll just quickly show a video. So we usually use the femoral venous sheath. In this case, it is a 10 French, and it has through it an 8 French catheter. So there is 2 French of space available to inject fluids, and we can inject easily into it. So we stop the ventilation, and then we quickly inject 5 cc's of hypertonic saline, 15%. We always start with a smaller volume, and then if we need to, we go up to 7 or 10, depending on the size of the animal and its state. And then you see here the loop shifting to the right nicely. And then you can analyze your parallel conductance here. So in terms of parallel conductance, the best piece of advice I can give to anyone doing this is always check your hypertonic saline. If you mess up your IVC occlusion, you can still get baseline parameters, but if you mess up your hypertonic saline, the only data you will be able to analyze is pressures. So one good method to make sure everything is okay is to always check your parallel conductance after you injected it. Stop your recording, select your volume shift, and quickly analyze it to make sure that your VP is not larger than your minimum volume, because otherwise you'll get negative volumes when you apply your parallel conductance, and that does not exist. So always make sure that you do this during your experiment. And in our experience, this happens more frequently than one expects, and therefore wasting a few minutes during the experiment can save you a lot of hours at the later stage. And finally, I'll just quickly show you how one could get the ventricath inside the ventricle without using imaging. So these will have to be done only through the carotid approach. At least I have no experience with this, and I have not heard of anyone attempting it through the femoral approach. In this case, because there is a straight path from the carotid artery into the ascending aorta, this can be done. And you can just introduce your catheter while performing transthoracic echocardiography, so no need for X-ray here. As you can see there, you have your pigtail catheter now touching the aortic valve. So your left ventricle is to the left, and your aorta is these 2 parallel lines with the valves moving in the middle. So you just have to pull back and forth and push the catheter forward until you are through the aortic valve. You can rotate the catheter, but in this case, we always want to avoid this, as it can cause damage to both the catheter and the aortic valve. So only do this as a last resort, or if you really need to do large animal PV loop and you don't have access to a fluoroscopy system. And I'll just go a bit forward because we're running out of time. So as you see here, one last push, and the catheter bends a little bit, but then it snaps into the LV. There you go. And then once you look at your loop, you can still get some nice loops. And you do the same thing with your Swan-Ganz catheter, which is very frequently introduced without fluoroscopy guidance. And the same thing for your IVC balloon, which you can measure outside until when you have to push it in, and you can always control ventricular pressures and inflate it at different positions to make sure you are in the correct one. So finally, once you go through all of these steps, you should be able to get a nice looking PV loop and be able to get your data. So either using single or biventricular analysis, analyzing through LabChart or other softwares, the main idea I want to pass along is that if done properly, and if you always double check your steps, performing PV loop analysis can be a very powerful technique to have at your disposal, as it allows for an in-depth analysis of ventricular function. So you don't have to trust me, but in my opinion, at the end of the day, all the hard work is worth it. So thank you for your time, and I'll be more than happy to answer any of your questions. Hi,
Hi.
everyone.
Thanks again for that presentation and all the videos. It's really helpful, and I think everyone seems so far to be enjoying it.
I hope it was clear, and I'm more than happy to answer whatever questions you guys might have. Should I just go through them, or
Yeah, I'm going to go through them for
Okay.
you, and you just provide your response. So the first one that we have is, do you use a ventricath only once? And if not, how do you decide when to change it?
So we reused the ventricath multiple times. So the one you saw on the videos was probably used around 20 times already. So, and this is what I meant by make sure that you introduce it carefully without creating any kinks on the catheter, because if you take care of the catheter, you can use them as many times as you'd like. I know this is not the answer that the 80 instrument is looking for, but if you really take care of your catheters, they will work for you for a very long time. We've had catheters that we've used around 50 times until they stopped working. And usually when they stop working is that you lose one or two segments, or your pressure signal becomes has a lot of drift or a lot of noise. Usually it's a very clear indication that the catheter stops working. But if you really take care of it, even if it has a few kinks on it, we've used catheters with a lot of kinks on them. The problem with the catheter kinking, and when I mean kinking, is like this very steep angles on the plastic part of the catheter, is that when you are pushing it through and you want it to be straight, it will never be straight. So you'll have part of the catheter pointing towards one place and the other part pointing towards another place inside the ventricle, and that can lead to weird segments. But if you avoid that, you can use your ventricath for several times.
Thank you so much. Our next question, is this system applicable to smaller animal models such as rabbits? And what size of catheters would you use in a rabbit, let's say 2 to 3 kilograms?
Good question. Actually, I do know that Millar and the instruments, they sell smaller catheters that can be used in rabbits. Every time we've performed PV loops in rabbits, we did it open chest, but I don't think that there is any kind of plastic. I mean, I would have to check, but I don't think that there are any kind of plastic catheters similar to the ventricath that could be introduced percutaneously into a rabbit. I'm pretty sure that there are no vascular introducers or introducer sheaths small enough for the arteries and veins of rabbits. So you'd have to do it like you do it in a mouse or a rat, so a surgically approach to the carotid artery and the jugular vein. But the problem is that probably the available catheters are metal, like the ones for rats and mice. So you have to go through the neck and not through the femoral vessels. But everything else, I guess, would be kind of similar. I think they even have multi-segment smaller catheters that could be applied to rabbits, but I'm not sure. I would have to get back to you on that.
Yes, and I'm sure 80 Instruments would be more than happy to help and answer a question like that. They're very familiar, of course, with their own product. Yeah. But thank you, Pedro. Okay, I noticed in your PV loop example slide, you seem to have Swan-Ganz as well as LV and RV PV catheters. Have you ever had any electrical interference occur due to the presence of the Swan-Ganz?
Only when using the continuous cardiac output catheter. Can I go back to a slide, Sydney, or is that too complicated?
No, we can do that.
So if I go to slide navigator and just go
Yeah.
slide I want, it's somewhere around here. So here. So if you see the bottom image, you see that there is a lot of noise on the third channel, so the second blue one. So first you have ECG, then you have uh, S1, or no, in this case is S2, and then the other one is S6, I think. It's too small for me to see, but as you can see, S2 is very stable, and then S6 is going up and down. And this up and down is when the thermistor, or the resistance in the continuous cardiac output catheter, is on. So when it is on, it does affect the conductance signal of the electrodes that are located more or located closer to the thermistor. But you can just stop the recording of the cardiac output during those few moments of baseline and IVC and hypertonic saline recording, and then turn it back on again just to make sure that your cardiac output did not really change. But yeah, we only see interference in those cases. Also, when we first started thinking about doing biventricular PV loops, we were very afraid of interference between the two ventricles, because we do see this in small animals. And we did know of another research group in Denmark that they were applying a filter to the volume signal that would remove this interference. But what we saw when we did it for the first time was that there was no interference between the two ventricles. So if you turn one off and then leave the other one on, the loop is exactly the same as when both of them are on. So only when you use another piece of equipment or catheter that's also creating an electrical current, then you have interference, but not with the ventricles themselves.
Okay, thank you so much. We have kind of a two-part question. Somebody asked you, what's the difference between a ventricath and a microcath?
So the ventricath is the pressure volume catheter, and the microcath is just a high fidelity pressure catheter. So it's these very small 3.5 French tip catheters that you can use to record pressure that Millar sells. And both those catheters can connect to the MPVS Ultra. And that's what I meant in the slide where you could connect those. So we only use the microcath when we want to get very high quality pressure on a specific vessel. For example, in our chronic thromboembolic pulmonary hypertension model, we do not rely on the fluid field pressure. So we always advance a microcath through the Swan-Ganz into the pulmonary artery to get really high quality PA pressure recordings, while the ventricath is a pressure and volume multi-segment catheter.
Okay. And then part two of that question is, does it use admittance technology or conductance? Does it provide conductance magnitude data and phase data, or just the LVP and LVV?
So it's a conductance catheter. So just conductance and pressure.
Thank you. All right. We have a question, a kind of experimental question. They're curious why you completely occlude the IVC. Does partial inclusion provide sufficient preload reduction, and blood comes from the SVC anyway? So they're wanting to know why you
not in our
completely
experience. If you partially occlude the IVC, the loop will not drop significantly in order for you to get a nice end systolic and then diastolic pressure volume relationship. So we always completely occlude the inferior vena cava. And if you are worried about too much preload reduction, the SVC is still open. So there's still, obviously you don't keep the balloon inflated for several minutes. It's just a few seconds. But in our hands, if we don't completely occlude it, it's not sufficient to have a nice drop in pressure and volume.
Okay, thanks. Since you're bringing the LV PV catheter through the ascending aorta, do you ever face any issues with aortic valve causing the PV catheter to be unsteady and move around?
That's a good question. That can be answered by how the loop looks like when you stop ventilation. If your loop is super stable, then in theory, this is not affecting your catheter positioning. If even after stopping ventilation, you still have a little bit of shifting of the loop back and forth, this could be the issue, or the catheter is too close to a papillary muscle, or something else, or another structure can be causing a change in the catheter position. We do see, not when we're performing pressure volume analysis, but the issue here is that you can actually cause damage, and it's much more frequent than what you would expect, to the aortic valve anytime you're going through it with a guide wire, with another catheter, etc. And that's why we always prefer the sheath approach with a dilator, because it perfectly fits the guide wire. So when you're going through the aortic valve, you have no option of an open hole catching a piece of the aortic valve and damaging it. Obviously, if you're just with a ventricath going back and forth, you're kind of scraping the valve, and maybe that will lead to a bit of regurgitation. And that is definitely true in the video you saw with the ultrasound-guided introduction of the ventricath. But that's a limitation of the technique. If you're going antegrade through the, or if you're going retrograde through the aortic valve, you're always prone to damaging it and causing a bit of regurgitation. Although we do believe, and it's what is commonly accepted, that it's insignificant to the hemodynamics variable.
Okay, great detailed response. Thank you so much. We have reached the top of the hour. I just want to let quickly the audience know that we will be sending a Q&A report to Pedro to answer all of your questions, and we'll send that out in an email. So continue to submit them, and he will get to them. Pedro, I just want to say thank you so much for your time and expertise today. It was such a pleasure to have you with us.
My pleasure.
Okay, thank you.
Thank you, everyone.
In closing, we hope you enjoyed this Inside Scientific webinar produced in partnership with the American Physiological Society and sponsored by 80 Instruments, and I hope that you enjoy the rest of your day.